Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode features content regarding ART safety and tolerability in patients with cardiometabolic toxicities. During this podcast, Dr. Priscilla Hsue, Professor of Medicine at UCSF, and Dr. Jens Lundgren, Professor at the University of Copenhagen, discuss key considerations when managing patients with HIV and weight gain and cardiometabolic toxicities. For more information about Dr. Priscilla Hsue and Dr. Jens Lundgren, and for a link to the full online educational program, please visit the link in the show notes for this episode. Now let's get started and hear what they have to say about ARV-related weight gain and cardiometabolic toxicities.
Hi, everybody, and welcome to this program on state-of-the-art of safety and tolerability of HIV treatments in patients with cardiometabolic toxicities. My name is Jens Lundgren from the University of Copenhagen, and I'm happy to introduce Priscilla Hsue. Priscilla, please.
Thanks, Jens. I'm Priscilla Hsue. I'm at UCSF. Delighted to do this today. Thank you. We have a patient case, and this is a 59-year-old HIV-infected gentleman who is Caucasian and a male. He has treated and suppressed disease. He's currently on bisotegravir, FTC, TAF. He comes to the clinic with these new complaints of weight gain. He does not smoke. He has no prior history of coronary artery disease or diabetes. His CD4 count is in the 300s and 400s. His viral load's undetectable. He's had a recent increase in BMI. His HDL cholesterol is 36, LDL 92. His total cholesterol is 180. He is not taking medications for his blood pressure or cholesterol at this time. So we'll discuss a little bit about how to ascertain his cardiovascular risk. But 6 months prior, it was approximately 6.6%, and currently it is 10.3%, which is an intermediate risk. So the whole risk calculator and risk prediction in HIV has been challenging. Using traditional risk calculators, which this is one of them, tends to underestimate risk in individuals living with HIV infection, particularly among individuals at intermediate or higher risk. There are several HIV-specific risk calculators that take into account duration of HIV and HIV medications, and so those were developed by DAD and others, but these have not been widely used yet. So if you use the ACC-AHA cohort calculator, it takes into account things like blood pressure, LDL cholesterol, diabetes, smoking, and things that you can modify depending on the calculations, like aspirin and cholesterol medication. This will give a lifetime risk as well as a 10-year risk. It should be used in patients who do not already have pre-existing cardiovascular disease, and it can forecast them the impact of having a well-controlled blood pressure or cholesterol or stopping smoking on patient risk. So generally, we consider low, less than 5%, calculate 10-year risk, borderline about 5 to 7.4, intermediate around 7.5 to 19.9, and high is greater than 20. And just to really underline that the most important way to prevent cardiovascular disease is lifestyle modifications, including controlled blood pressure, cholesterol, and diabetes as well.
Let's review the data that associate the antiviral treatments with weight changes. The ADVANCE trial presented back in 2019 clearly depicted that there was increases in weight, but certainly in this randomized trial, more so in people that was receiving dolutegravir in combination with TAF compared to dolutegravir compared to TDF. And less so in people that was receiving and randomized to efavirenz. It is also clear this weight increase were more pronounced in females compared to males. Among the integrase inhibitors, there is not a robust and large studies, but this compilation of results from two trials, 1489 and 1490, shows you the changes in antiviral-naive people until week 144 for people who's randomized to either BIC or dolutegravir. There appears to be a class effect here among at least the integration inhibitors. Importantly, in this compilation of 8 randomized controlled trials produced by Paul Sachs and colleagues in CID a couple of years ago, it is a bigger problem for females compared to males. The group that is experiencing the largest increase are Black females, more so than white females. Importantly, in this meta-analysis, it was also interesting to see across these 8 trials that, again, as we saw before, this weight increase appears to happen more frequently in people who's randomized to integration inhibitors compared to people randomized to PIs or non-nucleosides. It appears to be similar for the different integration inhibitors, maybe less so for dolutegravir and Cobi. And again, it appears to be more pronounced, at least in antiviral treatment, this weight gain in people randomized to TAF compared to TDF. So I guess, Priscilla, why do you think this is in particular a problem for integration inhibitors that they associate with weight gain, and in particular in Black females?
Yeah. So that's a $1 million question, Jens, and I wish I could answer that. I think we all know that there isn't. It's really unknown in the field. You know, there have been many different postulates, like, is this a return to health issue, or is it that TDF is associated with weight loss as opposed to, you know, TAF being associated with weight gain? Are these some kind of off biologic interactions like leptin? Is it from GI tolerability of the medication? I think really unknown, and just need a lot of work on this issue to better understand it. So OPERA study is a longitudinal prospective cohort analysis that looked at EHR data in approximately 8% of individuals in the U.S. who are receiving care. And this is over 100,000 individuals in 65 cities, including Puerto Rico. And this is looking particularly at individuals who switch from TDF to TAF in the U.S., and also individuals who switch from non-INSTI to INSTI-based regimens from 2015 to 2019. So overall here, there were over 5,479 individuals maintained on other antiretroviral therapies. These included 3,281 on integrase inhibitor regimens, 1,452 on NNRTIs, and 746 on boosted PIs. The analysis was restricted to individuals who received TDF-containing 3-drug ART at baseline, who had more than 2 consecutive HIV RNA levels, less than 200 copies, who switched from TDF to TAF. Switching to TAF was associated with early pronounced weight gain for all, and this ranged from approximately 1.8 to 4.47 kilograms per year. This effect with TAF was observed in patients maintaining other ART and those switching to integrase regimens, regardless of what agent was used. And over time, weight gains tended to slow down or plateau approximately 9 months after the switch to TAF.
So what you just heard is that it is quite clear that integrase inhibitors is leading to weight increase, in particular in some subgroups of patients, females and Blacks, for example. And this is seen both in people who are starting on treatment, but also in people who is already on antiviral treatment and being switched. Although the weight gain among people who is already on treatment is less so. But also, and importantly, that switching, for example, from TDF to TAF is associated and leads apparently to an increase in weight. And then there's a number of other factors as well that is associated with weight increase. We need to put all that into context, of course, because what is the concern with this weight increase? Recently, in the RESPOND trial, there was an attempt to associate exposure for the first time to integrase inhibitors with whether that is affecting cardiovascular risk, which could be a side effect from that weight gain. This was a large cohort of patients followed for over 6 years. around 30,000 people, of which around 750 developed cardiovascular disease during follow-up, giving an instance around 5 to 1,000 per year as a follow-up. As you can see on the right side of the slide, and quite surprisingly, that the instance rate of cardiovascular disease increased slightly to begin with, more pronounced in the first 6 months, and thereafter tailored off compared to those who was using other treatments. This is a surprising result. It's obviously a pharmacovigilance signal that needs to be further understood, but it's surprising in the sense that if it is actually correct, which we don't know, and therefore this needs to be reproduced in other cohorts, if this would be true, it would mean that there is an immediate effect by starting on integrase inhibitors that increases risk, but that is not durable. And one would have probably thought if there was a problem with weight gain, that if there was a problem in terms of increased cardiovascular risk, it will only happen after some time. Again, this is an active area of investigation. What is the consequence of drug-induced weight gain? But this is an early signal that needs to be further investigated. So, Priscilla, based on this, what should we consider in terms of managing this patient as a physician?
So I think this is a very important study that's providing some preliminary association between integrase inhibitor use, at least in the first 24 months, and cardiovascular risk. I think as you outlined, there's still many unanswered questions that we don't know about. We know in the general population that weight gain itself is associated with diabetes, hypertension, lipid abnormalities, and also increased cardiovascular risk. I think what we don't know in the setting of HIV is this weight gain going to worsen cardiometabolic issues and then also cardiovascular disease. So kind of in the absence of that data at this time as clinicians, I think really strongly addressing all the reversible risk factors, like keeping close tabs on hypertension, lipid levels, diabetes levels, and then using medications to control those parameters are very important. Also, carefully monitoring weight. I think it is really interesting that, as you alluded to, why is that risk there in the first 2 years and then not after? Is this, from thrombotic issues? Is this something then that potentially aspirin might be useful for? Is it from immune reconstitution, inflammation? So I think it brings up a lot of interesting questions for the future. So next we have the TANGO study. And so this is a multi-center randomized open label study, non-inferiority, looking at switching dolutegravir 3-TC fixed dose combination in adults on a 3 or 4 drug TAF-based regimen. A subset then continued on TAF-based ART, and then a subset switched to dolutegravir and 3-TC, and they allowed continuation of the dolutegravir 3-TC regimen. There were secondary exploratory analysis done looking at the impact of these regimens on weight, lipids, inflammatory biomarkers, as well as renal biomarkers. Individuals could not have HBV or HCV co-infection as well. Interestingly, the changes in weight were similar between the groups. There were some fluctuations observed in patients with baseline obesity that may have been impacted by weight management interventions. There were also changes in fasting lipids that seemed to be more beneficial in the dolutegravir 3-TC arm. And overall here, you can see there were minimal changes in the inflammatory or immune activation markers. Overall, the LDL was lower in the dolutegravir 3-TC arm, along with triglycerides, as shown on the right-hand side. However, the HDL was lower too.
So this is really interesting, Priscilla. Thank you. So switching to dolutegravir and 3-TC did certainly not lead to a reduction in weight gain at all. But as you showed, maybe something to consider in people that have dyslipidemia as it appears to reduce that modestly compared to the other regimen that you saw in that slide. Obviously, we need to be conscious of the fact that when we try dolutegravir and 3-TC, there shouldn't be any acquired drug resistance in those patients that we do that on. Now, another possibility is to consider one of the newer non-nucleoside reverse transcriptase inhibitors, for example, Rivaroxaban. This trial, Drive Forward, was a randomized double-blind phase 3 trial that assessed people who was antiviral naive in terms of whether they would benefit from Rivaroxaban in combination with two investigator chosen nucleoside analogs compared to people that was randomized to ritonavir in combination again with two nucleoside. What is important is that the trial was designed in such a way that the patients were followed on the allocated medicine for 96 weeks. Biologically, the two arms behaved fairly similarly with similar high proportion who is biologically suppressed. What was interesting was that in the first 96 weeks, in those allocated to Rivaroxaban, a slightly increased weight increase compared to people randomized to ritonavir, although the weight increases were modest. Interestingly, for those who is then switched at week 96 to Rivaroxaban, you also see a weight increase there. For those originally randomized to Rivaroxaban, you see a slight increase in lipids compared to the state prior to starting treatment. But quite impressively, for those who were originally randomized to ritonavir, once they experienced and did the switch to Rivaroxaban, you see a reduction in lipids compared to an increase in the early part of the study. So this is a possibility, again, for people with perturbed dyslipidemia. Importantly as well, when we consider drugs that needs pharmacological boosting, and just this is really a reminder that the combination of medicines is slightly more complicated due to drug-drug interactions, in particular for common antihypertensive, but also for drugs in other drug classes.
Wonderful. That was an excellent overview of the studies. So the DHHS guideline recommendations, to summarize, are some of the following points, and we've talked about a lot of these. Namely, the significant weight gain may occur with all ARV regimens, but it is likely more pronounced with dolutegravir, bisategravir, and TAF. So, of course, discussion with the patient on lifestyle modifications, dietary interventions should be performed. ARV-associated weight gain should be a factor to consider, particularly when initiating or changing ART in Black women. To date, it is unclear whether switching to a non-integrase regimen will result in reversal of weight gain. And as Jens and I had discussed, the underlying mechanism for this weight gain, the association with cardiovascular, diabetes, pregnancy outcomes, and other age-related comorbidities in women with HIV remains currently unknown.
So the key take-home points from this session. As you heard, weight gain is more pronounced among persons initiating ART than those who's already on ART. And it is unclear if this reflects a return to health versus a drug effect, although there appears to be clearly also a drug effect, but certainly other factors as well. Risk factors associated with weight gain include antiviral medications, including integrase inhibitors and TAF, as well as non-antiviral treatment risk factors such as BMI status, those underweight or with low BMI, female patients, as well as Black persons. Obesity is linked to traditional metabolic comorbidities, for example, insulin resistance, dyslipidemia, and hypertension. But we do lack data in people with HIV, and this is a remaining and ongoing active area of research. What is really important is that healthcare professionals should treat the metabolic disturbances that they observe as they're treating patients with the different medications, and also reflect on at the moment there's little evidence to support changing ART to reduce weight gain, but some changes may benefit some of the metabolic comorbidities, and we have tried to illustrate that. So let's get back to the case Priscilla presented early on. So Priscilla, we have a problem here, at least a potential problem, because the patient is complaining of weight gain. The BMI have increased from 23 to 26, and you have calculated that the 10-year risk of atherosclerotic cardiovascular disease events have increased from 6.6% to 10.3%. What would you consider here when you see that patient in front of you differently than just continue on antiviral treatment the way the patient is?
Well, thanks, Jens, for circling back to this case. As you recall, this individual had a 10.3% calculated risk using the ACC-AHA cohort equations. So with respect to his traditional risk factors, I think it's very critical to continue to monitor his blood pressure, monitor his cholesterol, as well as his weight over time. If his blood pressure continues to be high, I would consider starting antihypertensive medications. His LDL is now 92, and because HIV is considered a risk enhancer, consideration of starting statin therapy could definitely be started in this individual or discussed as well. I think the final thing I discussed is aspirin use. With respect to primary prevention, the use of aspirin is falling out of favor somewhat. We also discussed a lot about different antiretroviral regimens and weight gain. At this point, there's probably not enough data to consider switching this patient to an alternative regimen. However, over time, if the weight gain issue continues to be a problem, the consideration of switching to dolutegravir and 3-TC in the TANGO study could be considered, as well as using doravirine in the DRIVE-FORWARD study.
Thank you very much to Dr. Priscilla Hsue and Dr. Jens Lundgren, and thank you to our listeners for joining in. As a reminder, to view the full state-of-the-art, applying up-to-date safety and tolerability data to individualized HIV care program on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back for more episodes on important infectious disease topics. Thank you.